So there were a lot of issues discussed. Obviously, the whole story started with docetaxel back in 2004. We didn't actually talk about chemotherapy this evening. Let me just ask briefly, and anybody can answer this, where do people feel chemotherapy has its role to play in the present time? So if anybody, Dana, do you want to kick off?
If I can get this to work. So I think that, as we mentioned today, there are a lot of treatment options now for our patients, and really the only way to answer that is to say that we need to better understand individual patients' tumors and how they respond to different treatments, and using Chen's organoids and Howard Scher's circulating tumor cells, Michael's imaging studies, we can better understand which tumors are more AR-driven and not. There's also some data to suggest that docetaxel may have an effect on the androgen receptor itself, so it may also be an AR-targeted therapy. So I think that there's room for all of the treatments that we have, whether they're radiopharmaceuticals or immunomodulatory agents, chemotherapy, AR-targeted drugs, but the challenge really remains to make precision medicine a reality for prostate cancer, as it is for so many other cancers, as Chen just showed for our patients.
Do you think that, or does anybody think that, given that the microtubules bind the androgen receptor at the N-terminal end, that the maybe chemotherapy might have a role to play in the splice variants when they become available? I mean, I'm just throwing that in the air, batted down if you like, but what do people think?
Well, I don't think it really matters what we think, it's what we can prove.
Right.
What we find is we may detect mutations or we may detect splice variants, but the whole tumor is not splice variants.
Yep.
So you see the heterogeneity within individual cells, you see it across cells. And keep in mind, although these drugs have been shown to improve survival, they have not shown to eliminate all tumor. So what behooves us is to try to understand what combination of drugs might be more effective. And as we've seen, unfortunately, despite a number of attempts to build on docetaxel, we've been largely unsuccessful by developing docetaxel combinations. And in fact, in some cases, the outcomes were worse.
Okay, the other thing that stuck out there was very interestingly was the P10 deletion issue, which you raised, and which I think people are very conscious of. Obviously, the clonal selection theory, which this would be part of, I guess, as opposed to the adaptive theory, which people concentrate in relation to the androgen receptor. So let's just think about that case. You and I were both talking about it before we started, the case in JCI where this small Gleason 3 contained a P10 deletion, which was actually the thing that killed the patient 17 years later. They said in their summary of the case that this was just one case. What do you think this is a real thing? Is that something they just a chance finding, or do you think it's something that we really are going to have to become aware of?
So I think with P10 deletion now is probably the most or the only prognostic biomarker that we have. And molecular prognostic biomarker. So I think over time, part of not asking for P10 is because doing the IHC has been hard, and now I think it's been, our lab, the Hopkins lab, various places can really do it in a reproducible manner. I think. We just have to prove that it can also be a predictive biomarker that would drive us to look at it. I think over time, we're talking about doing one thing, and soon enough, if you were to take away one thing, it's that 5 years from now, you're just going to do everything because it's cheaper to do everything than 2 or 3 one things, and then we have to.
So it's an interesting area. I could spend a lot of time talking to you about SPOP and its relationship to the fusion genes, which obviously are the absence of them, which is of interest. But let's move on because we have a limited amount of time, and I just want to, Michael, you raised the question today, and I'm going to raise it again, which is how in heaven's name can an agent that just has a penetration of 0.1 micro-angstrom units save lives?
That is the million-dollar question, isn't it? And if I had the answer, I'm not sure that I would be here this evening. I would be in Stockholm and collecting my award.
Let me ask you, let me put it more direct. So let's say that I said to you, we're looking for a biological explanation, whereas actually it might just be a physical explanation relating to skeletal related events or something like that. Would that be a possibility?
No, I really do think there's biology there.
Okay.
And there's been no agent that has delayed skeletal-related events as its exclusive benefit that has translated into a survival benefit. So I think the SRE prevention actually is a byproduct of what you're doing in terms of the cancer behavior.
Right.
And indeed, that's been shown with bisphosphonates as well. If you can well control the cancer, you can control skeletal-related events as well. And I think that the interesting thing is here is that we actually have an untapped well of therapeutic approaches that we don't understand, a completely new field of research, and there surely has to be a better marriage of the basic scientists in bone biology and prostate cancer than there's been to date. How this really works has to go back to the lab and animal models so that we can figure this out in a way that, you know, taps into this and develops a new platform other than what we have now. If you look at where we would be going with radium, it's going to be going in many of the paradigms that have been well trodden in all cancer. You take what you have, and you start mixing and matching it with the other drugs that you have, you start positioning it in other places in the disease, but that is not the doorway into an entire new field. That is much of the rehashed alphabet soup approach. We can't afford to waste that time.
Thank you. So Howard, you very elegantly and most interestingly showed us the way of assessing and evaluating tumor markers. You concentrated on the circulating tumor cells. Now, the question that I have is, we know that some of the circulating tumor cells are free in the blood. We know that rather a lot of them aren't, that they're covered and coated in platelets. Is there any way that you can see, rather than just accepting, now you began to show us ways that that you were moving forwards in this area, but ways of improving circulating tumor cells as a method. What's your perception of that?
Well, the first thing is we have to be consistent in what we measure. PTEN is probably one of the most common deleted genes, but if you get a group of pathologists and give them the same specimen, you'll see very marked differences in the interpretation of that specimen. So in point of fact, the Department of Defense has given 5 centers a focused effort on analytically validating pathologic assays. So how do we establish consistency amongst the type of antibody that's used, the conditions in which the antibody is incubated, what's the specific counterstain that's used, so that we can in fact compare apples to apples and not apples to oranges. If you look at various protein markers, it can be reported by the percentage of cells, but if you look in one region of tumors, it's very concentrated, another region is completely different. When in fact we lock pathologists in a room, again, what they could call is the absence of PTEN consistently, but not the frequencies. For circulating tumor cells, if you start to see clusters, those patients do particularly poorly. This has been found in a number of different tumor types. You can think of these as microemboli. In many cases, it's a late-stage event with very high tumor burdens and is a very prognostic factor. But before we can actually ask the question, we have to be sure of the measurements. And again, what we're seeing now in individual cells, we will have to figure out really how to record the information. The EPIC platform generates 96 different parameters per cell. So do the math. If you have 100 cells, it's an enormous amount of information. So this is all part of that process that's essential for us to see what these biomarkers actually mean.
I think if I could just add on to what Howard was just talking about, that applies to the imaging world as well.
Yeah.
And to some degree, the scientific interests in biomarker development run counter to the commercial interests. You'll very rarely get 2 image machine makers that say, you know what, my camera takes exactly the same thing as that guy's. It's no better and it's no worse. And that, of course, no company's going to say mine is just as good as the other guy's. Everyone wants to say mine has an extra whistle and an extra bell, can image better, it can image more. And so when you're trying to develop imaging as a biomarker, what you're really trying to say is you take the same picture on this machine in the US and you take take the same picture, the same patient in Ireland, you will get exactly the same picture. And so you do need to get everybody on the same page in terms of biomarker development to start beginning to look at that reproducibility issue. Just like with PI3 kinase, you have to get different pathologists in line so that everybody's using the same assay and getting the same result. It's true as well of the imaging.
Right. So I just want to, if you think about the different hallmarks of the malignant process, we've seen examples with biologic agents where you don't shrink tumors, we don't see PSA go down, and in fact the patient lives longer. So there are many other aspects besides slowing down growth rates, just simply preventing cells from metastasizing intuitively would make sense as something that's a good thing for a drug to achieve. What we have to do is, again, learn how to incorporate measurements of those processes in the way we evaluate drugs. For the biologics in particular, how is the dose determined? It's not the traditional more is better. In some cases, more may be worse. So these are the challenges we face moving forward, but the important things is there are many different aspects of the malignant process that we can affect that will benefit patients.
Well, Dr. Murphy.
I was going to be anonymous, and now I have to know what I'm going to say. Before you close, John, and just on behalf of the Society for Translational Oncology, I'd like to just pose not so much a question but a commentary. That really what we have here is an example, I think, of superb collaboration. It just happens to be under one roof, or at least in one institution, but that there are really hand-picked, and John, you gave superb questions to each of the presenters that described in detail the expertise that they talked about. But the complementarity of these four real gems shows us not only the biology and the diversity of that biology in this vexing cancer, the challenges of clinically approaching patients with now a plurality of drugs of which we know naught about with regards to their combination or sequencing, and yet now looking forward, really venturesome, not only at imaging but also at the genome itself, and placing all of that in context requires this kind of a dream team. And I want to thank you, Mr. Chairman, for a wonderful interlocutor. Thank you.
Well, Marty, you told me not to thank you, but I'm just going to show you how completely unreliable I am. Marty, thank you very much for this series, which is a great idea, and for all of the reasons that you've just said, to get a team like this together. And the interesting thing was that even at the end of 3 hours or whatever, 2.5 hours, the discussion could have gone on for another half an hour. It's quite amazing, and it just shows you the interest and the sort of determination to try and find the right answer that exists in Howard's department in Memorial Sloan Kettering. So all I have to say is, once again, to thank you, the speakers, so much for entertaining us. I feel that what an audience needs is a mixture of entertainment and education. And I believe they got that tonight. And so I hope that everybody will leave here on the way to the bar, on the way home feeling that they had a good evening. So thanks to our panel, and thank you very much to everybody for listening. Thank you.